In protocol AC, we took patients who had an eye with a visual acuity of 20/50 to 23/20 visual acuity and randomized them to two treatment protocols, one being aflibercept or Eylea monotherapy, and then randomized to the other group being bevacizumab or Avastin first. And starting at 3 months, if there was suboptimal response, we can switch those eyes to Eylea to see if they would do better. Overall, during the 2-year period, about 2/3 of eyes were switched in the arm that started with Avastin, switched from Avastin to Eylea. So the study showed that when you compare the two arms of the study, the Eylea alone approach was not cost effective because the other arm, where you started with Avastin and then switched only if necessary based on protocol criteria, you could achieve equal visual results at 2 years at significantly lower cost. I think that conclusion needs to be made with some caution. This is a well-controlled clinical trial in patients that are deemed reliable, can follow up, met the criteria for the study. There are, patients, often diabetic patients, do not follow up regularly. So if you start them on something which for them would be less effective, ultimately you may never see the benefit of the stronger drug. I think clinicians have to use these clinical trials as a guide and probably a clinician could determine that there are patients in their clinic where this approach could be used. However, there are other patients in their clinic where they may just decide that Eylea from the start, if they're 20 or 50 or worse, would be the most prudent thing to give them the best visual acuity going forward. And we have to be very cautious too that diabetic macular edema is a forgiving disorder. Other conditions in retina, for instance, age-related macular degeneration, if you lose that benefit early on, you may never get that back. So we're looking at just one condition where this showed equal benefit for the two approaches. There is some concern that insurers would use this study to validate their requirements for using a lower cost drug for retinal conditions initially, and then only switch if there's suboptimal response. Again, I think for this particular population of patients, there was no difference, but we could potentially envision other studies looking at other retinal conditions. And until that's the case, where there's some scientific basis for starting with a lower cost drug, which is less effective for many patients, and then ultimately switching, I don't think we should, I don't think insurance companies should use this to extend their validation for step therapy overall. I think that this study can help clinicians decide how to manage their patients. In my own clinic, for instance, let's say I have one patient where one eye has poor vision and I'm treating the better eye with center-involved diabetic macular edema. That patient's still very functional, maybe driving, working. Every month of better vision for them can make a difference in their life. If that's the case, I would probably start that patient on Eylea right off the bat. However, let's say I'm treating their worse eye, and they can still be very functional with the better eye. I know that this study has shown that there, as I mentioned, there doesn't seem to be harm in starting with the lower cost, maybe less effective drug, and then switching if necessary. So I may be more apt, because I would look at the financial impact to our society of starting that worse eye on the lower cost drug, explaining to the patient what we're doing and having their agreement, and then, but following that patient closely and then switching them as soon as it looks like there's a suboptimal response.